Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 378 of our pharmacotherapy series, which majors in pain and its management. The first question of the next case reads: DOK is a 35-year-old male admitted for elective surgery of an inguinal hernia that has been present for 8 months. The hernia presented as a protruding bulge, 4 cm in diameter, in the lower right abdominal quadrant that was noticeable with standing and retracted inward when lying down. There was no pain initially with the hernia or incarceration of internal structures, so conservative management with observation was appropriate until approximately 4 weeks ago, when the patient noted the size of the hernia was increasing and experienced pain shooting down the right leg when walking. An ultrasound of the right groin confirmed an inguinal hernia sac, 6 cm in diameter, with no incarceration. The patient was scheduled for an open repair using the Liechtenstein technique with polypropylene mesh reinforcement of the anterior abdominal wall. The first question of the next case reads: DOK is a 35-year-old male admitted for elective surgery of an inguinal hernia that has been present for 8 months. The hernia presented as a protruding bulge, 4 cm in diameter, in the lower right abdominal quadrant that was noticeable with standing and retracted inward when lying down. There was no pain initially with the hernia or incarceration of internal structures, so conservative management with observation was appropriate until approximately 4 weeks ago, when the patient noted the size of the hernia was increasing and experienced pain shooting down the right leg when walking. An ultrasound of the right groin confirmed an inguinal hernia sac, 6 cm in diameter, with no incarceration. The patient was scheduled for an open repair using the Liechtenstein technique with polypropylene mesh reinforcement of the anterior abdominal wall. After surgery is completed in the operating room, patients are transferred to the PACU for stabilization of respiratory function and pain. Most patients emerging from general anesthesia are still quite sedated when they are transferred to the PACU. When the anesthetic agents begin to wear off, it is very important to achieve rapid control of severe pain, so frequent administration of small intravenous opioid doses is common practice in this setting. Currently, there is not a universally accepted standard for titration of intravenous opioids in the PACU. Some institutions will allow use of both intravenous fentanyl to gain fast pain control and morphine for a longer duration of action. Hydromorphone is an acceptable alternative to morphine for patients with renal insufficiency or intolerable side effects to morphine. Morphine is considered the standard for intravenous opioid administration. The hydrophilic, i.e., water-soluble, property of morphine delays penetration across the blood-brain barrier, so the relative time to onset is approximately 6 minutes after an intravenous dose. The concentration peak effect, i.e., equilibration time between the plasma and brain, after an intravenous morphine dose is 20 minutes. Major morphine metabolites include morphine 3-glucuronide, abbreviated as M3G, and morphine 6-glucuronide, abbreviated as M6G. The morphine 3-glucuronide metabolite is inactive, but morphine 6-glucuronide crosses the blood-brain barrier and has potent analgesic activity. Therefore, the analgesic and ventilatory depressant effects of morphine and morphine 6-glucuronide may not be evident with initial high plasma morphine concentrations. Adverse events may occur 40 to 60 minutes after the last intravenous morphine dose. Patients with renal insufficiency will have morphine 6-glucuronide metabolite accumulation and be at increased risk for respiratory depression, so morphine use is not recommended in this population. Hydromorphone is commonly used in patients who cannot tolerate morphine or have a history of renal insufficiency. Hydromorphone is a hydrogenated ketone analog of morphine with slightly higher lipid solubility. The concentration peak effect after intravenous hydromorphone administration is between 8 and 20 minutes. Hydromorphone has a similar metabolic pathway to morphine-producing hydromorphone 3-glucuronide, abbreviated as H3G, and hydromorphone 6-glucuronide, abbreviated as H6G. However, hydromorphone metabolites are devoid of analgesic activity, but hydromorphone 3-glucuronide has been shown to accumulate in animal models, leading to dose-dependent myoclonus. Fentanyl is a synthetic phenylphosphoridine compound with high lipid solubility, resulting in rapid transfer across the blood-brain barrier. The concentration peak effect after intravenous fentanyl administration can be seen within 4 to 6 minutes. Fentanyl is a good option for rapid pain control, but may accumulate in adipose tissue with multiple doses. Therefore, it is not the best choice for obese patients. For management of DOK's pain in the PACU, the morphine order should be changed to intravenous hydromorphone at 0.2 to 0.4 mg every 10 minutes for severe pain. Hydromorphone does not have appreciable metabolite accumulation with renal insufficiency and does not distribute into adipose tissue. After DOK's pain is stabilized in the PACU, the interval will need to be longer between doses due to the declining acute pain trajectory and addition of other multimodal medications that will decrease the opioid requirements. In addition to pain management, it is very important to anticipate postoperative nausea and vomiting, abbreviated as PONV, caused by anesthetic agents and opioids. Antiemetics are commonly used for prevention of severe postoperative nausea and vomiting. My next question to you reads: is DOK an appropriate candidate for intravenous patient-controlled analgesia, abbreviated as PCA? For postoperative pain management after discharge from the PACU, the oral route is preferred over intravenous administration unless the patient is unable to use this route or has severe uncontrolled pain. The use of patient-controlled analgesia provides a precise and convenient method for intravenous opioid administration that allows the patient to activate the dose for acute pain management. The intravenous patient-controlled analgesia route is preferred over nurse-administered intravenous doses because the patient does not have to notify the nurse when more medication is needed, wait until it is given, and then further wait for the peak effect to occur for pain relief. Self-administration of smaller and more frequent intravenous opioid doses reduces the variation between the peak and trough effect of the dosing interval, thus better maintenance of the plasma opioid concentration. Evidence-based guidelines on the management of postoperative pain strongly recommend use of patient-controlled analgesia for the intravenous route in surgical patients, because of ileus, aspiration risk, or inability to take medications orally or enterally. Patients who are appropriate for patient-controlled analgesia must be able to cognitively understand how to use a dose button for opioid self-administration and require intravenous opioid for many hours. The patient-controlled analgesia dose button is connected to an infusion pump that will allow the administration of an opioid dose when the button is pushed, i.e., demand. To prevent overdosage by continual demand, all patient-controlled analgesia devices use a lockout interval, which is the length of time after a successful patient demand during which the device will not administer another dose even if the patient pushes the button. Most patients who start intravenous patient-controlled analgesia are opioid naive, meaning that their opioid use the week prior to surgery was less than 60 mg of oral morphine or its equivalent. For this reason, the starting dose for intravenous patient-controlled analgesia is standardized for opioid-naive patients. Use of a continuous opioid infusion for postoperative pain management is generally reserved for patients who are opioid tolerant and were taking opioid medication around the clock prior to surgery. The role of the continuous infusion is to provide a steady baseline of opioid medication that mimics the dose taken prior to surgery. Equianalgesic dose calculations are used to determine the dose difference between two opioids to provide the same degree of pain relief. When switching between two opioids, it is recommended to decrease the new calculated dose by 25% to 50% to account for incomplete cross-tolerance that may occur. Use of intravenous patient-controlled analgesia along with a continuous infusion in opioid-tolerant patients can help fine-tune pain control. Respiratory depression remains the most serious adverse event related to opioid therapy, often due to excessive amounts or frequent use of opioid medication beyond what is needed to achieve pain control. There are many factors that increase the risk of opioid-induced respiratory depression, with intravenous patient-controlled analgesia related to comorbid medical conditions. Patients with advanced age above 65 years, renal insufficiency, history of sleep apnea, or morbid obesity are at higher risk for developing opioid-induced respiratory depression. To prevent respiratory depression in high-risk patients, the lowest possible starting dose of an opioid should be initiated, and use of a continuous infusion should be avoided. For all patients, avoid administration of more than one drug with sedating properties at the same time with opioids. Medications including antihistamines, benzodiazepines, gabapentin, pregabalin, and skeletal muscle relaxants should be scheduled approximately 2 hours apart to prevent accumulation of sedating side effects. For hospitalized patients who experience excessive sedation and cannot be aroused with sternal stimulation, or have a significant decline in breathing, naloxone administration may be needed to reverse the opioid CNS effects. Naloxone is a non-selective competitive opioid antagonist of all pharmacologic effects on mu, delta, and kappa receptors. After oral administration, naloxone is extensively metabolized in the liver, i.e., greater than 95% first pass effect, and not effective, so intravenous, intramuscular, or subcutaneous administration at a dose of 0.4 mg is required for reversal of life-threatening respiratory depression. The extent and duration of naloxone reversal of opioid-induced respiratory effects is highly variable and is related to many factors, including the specific opioid used, the opioid dose, administration mode, concurrent medication, underlying disease, and pain. Therefore, naloxone administration may need to be repeated every 2 to 3 minutes or given as a continuous infusion until full recovery of respiratory function. In this case, patient-controlled analgesia therapy would be appropriate for DOK based on the invasive surgery and anticipated severe postoperative pain. Hydromorphone 0.2 mg intravenously, with a lockout interval of 10 minutes is recommended because DOK is at high risk for respiratory depression, being opioid-naive, morbidly obese, and having chronic renal insufficiency. Because DOK is experiencing sedation due to morphine administration in the PACU, the patient-controlled analgesia dose should be started after he is more alert. Other analgesic medications that are not sedating should be used to provide synergistic pain management and can be used throughout the postoperative period. As soon as DOK can tolerate oral medication, the intravenous patient-controlled analgesia dose should be discontinued and a short-acting oral opioid such as oxycodone or hydromorphone administered as needed with frequent reassessment of pain. Because DOK is opioid-naive, the lowest starting dose should be prescribed, so oxycodone 5 to 10 mg every 4 hours as needed or hydromorphone 2 to 4 mg every 4 hours as needed would be options in this case. Oral short-acting morphine is not recommended due to concern for metabolite accumulation with renal insufficiency. Long-acting oral formulations, i.e., sustained or extended release, should be avoided in opioid-naive patients who cannot tolerate around-the-clock opioid administration for a prolonged period of time. Recent guidelines for postoperative pain do not recommend long-acting oral opioids due to the need for pain titration with short-acting opioid, and studies have not shown that pain control with a long-acting opioid is superior to short-acting opioid administration immediately after surgery. When DOK is ready for discharge, a prescription for a limited supply of short-acting opioid should be written to cover the duration of 3 days. This is particularly important because prescription opioid abuse is a national crisis and prescription opioid overdose is now the leading cause of unintentional deaths in the United States. It is estimated that 35% to 80% of people addicted to prescription opioids report that they were first exposed to opioids for the legitimate treatment of pain, including post-surgical pain. The use of non-opioid medication can help reduce the need for opioid therapy. The next question reads: what other non-opioid medications would be helpful in the management of DOK's postoperative pain? Recent guidelines on postoperative pain management reviewed studies on acetaminophen and non-steroidal anti-inflammatory drugs in conjunction with opioids and found that the combination of both medications is more effective than either drug alone in reducing pain and opioid consumption. Perioperative oral acetaminophen at a dose of 1000 mg 3 or 4 times per day for 48 hours after surgery in adults with normal liver function is supported in the literature. After the initial postoperative period, the dose should be reduced to 650 mg and administered on an as-needed frequency. To reduce the risk of liver toxicity associated with acetaminophen daily totals exceeding 3000 mg, patients who will need opioid therapy should not be prescribed combination products containing acetaminophen such as oxycodone, acetaminophen or hydrocodone, acetaminophen. Use of intravenous acetaminophen has generally been reserved for patients who cannot take oral medications after surgery and cannot use non-steroidal anti-inflammatory drugs due to increased risk of gastrointestinal bleeding or renal insufficiency. Most research indicates that there is no clear difference between intravenous and oral acetaminophen in reducing postoperative pain. Compared with acetaminophen, non-steroidal anti-inflammatory drugs are more efficacious for reducing postoperative pain due to their anti-inflammatory effects. Most of the oral non-selective non-steroidal anti-inflammatory drugs are comparable in efficacy, so selection may be influenced by other factors such as cost, availability for use over the counter, and lower cardiovascular adverse effects. All non-steroidal anti-inflammatory drugs are contraindicated for management of perioperative pain in patients who undergo coronary artery bypass graft surgery because of an increased risk of cardiovascular events. Intravenous ketorolac is a non-selective non-steroidal anti-inflammatory drug and very effective in reducing postoperative pain. The recommended ketorolac dose for adult patients younger than 65 years with normal renal function is 30 mg every 6 hours as needed. For patients over 65 years of age or with mild to moderate renal failure, the dose of ketorolac must be reduced to 15 mg every 6 hours as needed. The maximum duration for ketorolac administration is limited to 5 days to prevent adverse events related to gastrointestinal bleeding with prolonged use. It is not recommended to administer ketorolac to patients who are hypovolemic postoperatively due to excessive blood loss or dehydration due to the risk for renal injury. Gabapentin or pregabalin are neuromodulators that are helpful in reducing postoperative neuropathic pain. The initial dose should be based on the patient's use prior to admission. For patients who were not taking gabapentin or pregabalin for chronic pain prior to surgery, the dose should be titrated up from the lowest dose and adjusted for renal function. Patients who were taking gabapentin or pregabalin for pre-existing neuropathic pain prior to surgery should have their dose and frequency resumed as soon as possible postoperatively to prevent uncontrolled chronic pain. The use of ketamine is becoming increasingly popular postoperatively in patients with a history of chronic pain that is poorly responsive to traditional analgesic medications, including opioids. Ketamine is a NMDA receptor antagonist that is effective in decreasing central sensitization after surgery. There is insufficient evidence in the literature on the optimal ketamine dose and duration of use postoperatively. Doses for postoperative intravenous ketamine bolus dosing or continuous infusion range from 0.1 to 0.5 mg per kilogram. The main side effect of postoperative ketamine is hallucinations, which can be mitigated by keeping the dose low. Ketamine is contraindicated in patients with uncontrolled hypertension. Intravenous lidocaine has been evaluated as part of multimodal analgesia in patients who underwent open or laparoscopic abdominal procedures. Studies showed that perioperative or intraoperative intravenous lidocaine infusions were associated with shorter duration of ileus and better quality of analgesia compared to placebo. In trials, lidocaine was typically administered as an intravenous bolus, that is 100 to 150 mg or 1.5 to 2.0 mg per kilogram, followed by an infusion of 2 to 3 mg kilogram per hour through the end of surgery. Topical local anesthetics such as the lidocaine 5% patch may be helpful for incisional pain, but its efficacy is limited due to lack of penetration into deeper tissues. DOK should have acetaminophen started at 1000 mg orally scheduled every 8 hours as soon as he is alert enough to swallow medication without risk of aspiration. Non-steroidal anti-inflammatory drugs should be avoided in the immediate postoperative period until his renal function can be evaluated. If DOK's creatinine clearance is greater than 50 ml per minute, ibuprofen 600 mg orally every 6 hours as needed can be used for pain because this was the patient's non-steroidal anti-inflammatory drug choice. Prior to admission, DOK was reporting pain shooting down the right leg but was not taking medication for neuropathic pain. If the shooting pain persists postoperatively, gabapentin started at a low dose of 100 mg orally scheduled 3 times a day may be helpful. Caution should be used with gabapentin in patients with renal insufficiency, which may require a dose adjustment. Intravenous lidocaine is generally not a first-line option for postoperative pain management and should be used only if pain control is suboptimal after maximizing other multimodal medications. Before DOK is discharged, plans should be made for prescribing the oral multimodal medications for a short duration of time because acute postoperative pain generally abates after 1 to 2 weeks. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 379.